Is it the truth? Is it fair to all concerned? Will it build goodwill and better friendships? Will it be beneficial to all concerned?
Good afternoon. I'm going to talk a little bit about behavioral health and then tell you about our hospital. Arguably, the biggest unaddressed health challenge in our community is behavioral health. Approximately 1 in 5 adults in our community will experience mental illness in a given year. That's 20%. 1 in 5 adolescents will experience a severe mental illness at some point in their life, and 1 in 10 adults will have a drug use disorder at some point in their life. Now these illnesses know no class boundaries, no geographic boundaries, no age or racial boundaries. From the people living with schizophrenia or bipolar disorder to those folks dealing with bouts of depression or anxiety, this is really an illness that can affect anyone. I talk about it is everybody's neighbor, everybody's family, everybody's coworker, and it really is. Yet no one brings you casseroles when your parent or child is hospitalized for a behavioral health condition, and the person's nightstand isn't adorned with flowers and get well cards. Stigma lies in fear, and it's fed by misconceptions and inaccurate information. When most folks think about behavioral health in psychiatric hospitals, they still think about One Flew Over the Cuckoo's Nest. There's just so many false depictions of what we do, behind those doors. And as you'll see today, as I talk about Lancaster Behavioral Health Hospital, really nothing's further from the truth. Let's turn this on. There we go. So as you may or may not know, LBHH is a joint venture, and it's somewhat unique in that it is a 50-50 partnership with Penn Medicine, LGH, and UHS. And that really does allow us to bring the best of both worlds together. When we think about what we're trying to accomplish, we talk about our mission being treatment, compassion, and hope. And, we start with the premise that we believe recovery is possible for every person with a behavioral health diagnosis. And to help them address their recovery, we bring the best in evidence-based care to our treatment. So what does that mean? What is evidence-based treatment? Well, especially in healthcare, there's a lag between what the research says and what we know works and what we actually do. So we at LBHH really try to bring the best knowledge, the most up-to-date treatments, and those evidence-based interventions to what we do. So whether it's dialectical behavior therapy or trauma-focused cognitive behavior therapy or motivational interviewing, we use those interventions and therapies that the research has shown has the most likelihood of being successful. That and kind of state-of-the-art medication practices. I think the other piece that makes our treatment somewhat unique is that we're holistic in our approach. I think psychiatry in general has had this problem of what I say, cutting people off at the neck and just dealing with the head up. We understand that wellness is about mind, body, and spirit. So we have a paid chaplain on staff. We have a dietitian. We have a dance and movement therapist. We do a lot to keep folks physically active and well in terms of just their body and their mind feeling rejuvenated. In terms of compassion, we do understand that when that door locks behind you, people who seek services, no one's going, oh, thank God I'm in a psych hospital, this is great. They're either ashamed or they're angry because they're being held against their will. And we work with those individuals to try to give them as many choices as we can so that they don't feel so contained and put off. And we talk about the importance of hope. hope is the most significant driver of change. And if people don't feel hopeful, they're not going to do anything different in their life, and they're not going to direct their own recovery. So when the folks we serve, our patients, don't have hope, we have to carry that hope for them. This is the main entrance to our hospital. One of the things I like about our entrance is we have lavender planted on either side of the walkway. And that's very intentional, that we have had our staff trained in aromatherapy and essential oils. There is a whole science behind this holistic approach, and there is actually data and research that shows lavender works as an anti-anxiety. One of the other things that's kind of unique about our hospital is we spend 10 minutes every morning over the loudspeaker. We shut down and we meditate for 10 minutes. That's our doctors, that's our administrators, and that's our individuals in care. We actually use the online free meditations that are offered by UCLA. And again, this is no longer fringe stuff. Harvard has a whole website developed showing all the changes in the brain that occur after people meditate for as short as 6 weeks. So we really are trying to give folks the skills that they can use once they leave the hospital to stay well and healthy and not need to be readmitted. This is our lobby, and you might notice that it has really an abundance of light and a lot of windows. And that's very intentional. We really are trying to fight against the shame that's associated with seeking behavioral health treatment. You go to a medical hospital, you go to a psychiatric hospital. There's no difference. You're trying to get well, you're trying to get healthy, and we need to kind of fight that shame. I think historically psych hospitals were way out in the country behind big walls, and people would sneak in and sneak out because God forbid anybody should see you. That's not the approach we take. We are right in the community. We're actually adjacent to F&M's campus. We get a lot of walk-ins, and we're open and welcoming. You can look right in the windows. I also think, we do have, getting back to our holistic approach and, our whole theory of wellness, we have both indoor and outdoor activities. We have a certified dance and movement therapist. We have an art therapist. We have a music therapist. And as I mentioned before, we have these meditative and holistic therapies. We have a pet therapist that comes in every week. We just contracted with actually a harp therapist. We have spirituality groups, art, yoga. We really do try to offer a whole menu of options for folks to get well. When we talk about our vision and who we want to be for Lancaster, our community, we really do want to be your leader in behavioral health. We want to be the go-to people when there's a problem, when there's a concern. We want to be called upon to help. And, we do that through a few avenues. One is by taking seriously our responsibility to educate the public about the prevalence of behavioral health illness and the stigma and discrimination that exists, but also in providing services that are strength-based. And what I mean by that, I think historically, psychiatric treatment was all about problems and all about symptoms and all about negativity. And it's hard to, get up and be positive and want to change when all you're being told about is, this is your problem, this is your symptom, this is your diagnosis, this is what's wrong. We really try to focus on not just on what's wrong, but what's strong. What's your talent? What's your strength? And it can be something as minor as a smile, but those are the things we need to celebrate, and those are the things we need to remind people of so that there's a reason for them to try to change. We talk about trauma-informed care. We understand that most people who seek inpatient treatment have a trauma history. Statistics say like 70 or 80%. There's a whole literature that even says even being hospitalized in a psychiatric hospital is in and of itself trauma-inducing. It was interesting, I was talking to NAMI group last night, and they were saying how traumatizing it is to even visit someone in a psych hospital. And we work really hard on trying to not give that impression. When you see some more of the pictures, you'll see we were really going for an environment that's spa-like, that's healing, that's nurturing. but nonetheless it's traumatic. And so we recognize that, and we counter that by applying what's called universal precautions. So that means we don't yell, we don't scream. We really do try to create a serene, healing, nurturing environment. We work on positive clinical outcomes. I think unlike most hospitals, we actually measure, we measure symptomatology. We have perception of care surveys on discharge, so we can find out what people think about our hospital and how we might make some changes. And we've already made some changes. We've had some complaints about mattresses, and they weren't soft enough. So we purchased egg crates for some folks. We got a lot of complaints about the decaf coffee in the morning, which historically all psych hospitals only serve decaf. Well, why is that? Everybody likes real coffee in the morning. We changed it. We serve coffee. So I do think we systematically collect data, and we use it to improve our program. I mean, the other thing that, I feel is our personal responsibility is that I do think we have something special at LBHH, and we're doing something special, and we're trying to influence the next generation of behavioral health providers. So we have NP students, nurse practitioner students from the University of Delaware. We have Temple medical students. We have nursing students from Hack, Millersville, PA College. Not Millersville, what was the other one? Nursing students, York. We have social work students, MSW and PhD from Millersville College. We really do want to serve as a training ground and help prepare the next generation of behavioral health providers or people who might opt to go into this field, into this kind of state-of-the-art model. So this is what our nurses station looks like. And when we're fully functioning, right now we have 48 beds, we'll have 126 beds. So we'll be a pretty good sized hospital. We'll have 6 units, an adolescent unit with 24 beds, a psych med unit with 24 beds, a women's trauma unit with 16 beds, 2 general adult units with 24 beds, and a 16-bed intensive treatment unit. Now, our general adult units are the 2 units we have open now, and we did that intentionally because we didn't want to be in a position where we had a bed, but it was on women's trauma and a male needed admission. So the most flexibility we have is with our general adult units. So those are the 2 units we've opened. I think, when you walk through our hospital, and hopefully some of you have been able to see it and been to our open house or taken a tour, you will see that it really does have a lot of spaces that afford us to be able to fulfill this mission that I've talked about. One of the things we have, which is pretty unusual, is we have a beautiful gym with a basketball hoop that electronically lowers, a volleyball. We have all kinds of equipment. And again, this is so we can keep people physically healthy. I think that, oftentimes, even the medications we give folks in psych tend to cause some cardiometabolic issues and weight gain. So being able to get people outside and to exercise is important. This is our dining room, and again, you can see the big, beautiful windows. We actually look out back into the parking lot, like with CVS, where CVS is off Harrisburg Pike. And again, we keep the windows open. I think it reminds folks that you're here for a short period of time, you want to get back out. No one should be living in a psychiatric hospital. And I think just the openness just helps promote that we're not ashamed. One of the things I like best about our hospital is we actually have 7 courtyards. We have 2 that are internal, surrounded by building, so they have artificial grass, but we have 7 courtyards like this that are real grass. So the one in the upper left is our older adult courtyard, so it has a figure 8, so anybody who likes to pace or who want to walk around can. And the one in the lower right is our adolescent courtyard, and we actually have a basketball court out there. So just lovely spaces. This is an example of a patient room and one of our day rooms. So one of the things that's really nice about our patient rooms is they control their own lighting, which is not always the case in a psychiatric hospital. So we have night lights, overhead lights, and tasks like reading lights. All the individuals in care can control their own lighting. We also really have state-of-the-art ligature risk reduction. Unfortunately, still, sometimes, regrettably, individuals in psychiatric hospitals are able to complete suicide. And I say complete rather than commit, because commit makes it sound like a crime instead of an illness. So what we've done in our hospital, we've been very intentional about removing ligature risk and reducing ligature risk. So our shower spouts are flush to our ceiling. Our shower curtains, if you put any weight on them, they will rip down. Our blinds in our window are integrated in between two pieces of glass. You can't get at them. You know, everything from the sprinklers to the smoke detectors, everything is flush, that you can't loop anything around. This is one of our day rooms. Each unit has several rooms for groups. We have an active day room. They all have big TVs, ice machines, microwaves. The adolescent unit has a Wii. We have a quiet day room which has phones in it, also a TV which folks can use to call home. We have a group room. We have a consult room. It really is an environment that, even though when you come into a psychiatric hospital and that door locks behind you, you're still able to walk to the gym with your unit. You're able to walk to the dining room with your unit. You're able to go outside in the courtyard. In most psych hospitals, especially those in general hospitals, it's just one corridor, and you really can feel very trapped. So being able to have these options for space, to move around, and to really just, be able to learn how to self-regulate in all these different areas are very important. One of the rooms I like the best, we have what's called a comfort room on each unit, and it has a rocking chair in it, and it has some sensory items, and it's in this room. It's only used by one person at a time. It's totally voluntary, that you get to just, you get to practice those self-regulation skills. Because people normally aren't committed to a psychiatric hospital because they're psychotic. They're committed because they're screaming on the street and scaring people. So teaching folks how to self-regulate is really an important part of what we do so that we can increase their community tenure. I think, when you think about our approach to trauma, I think the other thing that's very unique about us is we use no 4-point restraint, we use no camisole, and we've only had one instance of seclusion. That's when you get locked into a very small room with no furnishings. So we really do take an approach that we have to help you early identify your triggers and early warning signs so that you don't become so dysregulated that you need to be physically held or physically locked in a room. We feel very strongly that when that happens, that's all you remember about your hospitalization. And that's not what we want to stand for or what we believe is appropriate for individuals who have mental illness. So this is an aerial view of our hospital. We actually have about 78,000 square feet. It is on 13 acres, and again, we have the 6 units. It's really quite nice. You can see some of the courtyards in there. And I guess the other thing I wanted to touch on is to ask you to take a look at our Facebook page, perhaps follow us. You can see we keep it very active. We post on it every week. We put some educational things on there, but we also put pictures of stuff that's happening in the hospital and what we're doing. We also have a LinkedIn page, and we have a really nice website where you can read about the background and history of the leadership team. To me, I think what also makes us unique is 60-70% of the executive team of this hospital has an immediate family member, myself included, with a serious mental illness. And I think that makes us just a little bit more attuned to first what the family experience is, but also, when we say we want to run a hospital that our family member, we'd be okay with our family member being served in, we really mean that. And so I do have to say that we've brought together a team that is committed, that is passionate, and that really do want to make a difference and serve this community. And you know, we see ourselves as being responsible for helping improve the mental health of Lancaster County and beyond. And that's kind of what we're destined to do. And this is my favorite picture of the hospital. And this is just, again, our entrance in the evening. And I guess I'll take questions. Thank you. Yes. Oh, okay.
Thank you so much for being here today, and that was extremely informative. What services and supports do you have in place for patients that have limited English proficiency?
So we actually have contracts with 2 different entities for translation. And we oftentimes bring translators on site. We also have a telephone service. Since a lot of our programming in a psych hospital is group programming, there's less individual work, there's more group work, we most frequently have translators on site. So we've had sign language, we've had Spanish, we've had several Chinese different dialects. We've had a lot of folks that needed translators, and we pretty much bring somebody in 7 days a week, 6-7 hours a day. It's a cost we bear, but it's important because they can't participate in treatment without it.
I'll add my thanks. Thank you for being here. Question I would have is, what do you do or what do you have for family members? Say I'm struggling with someone in the family, really needs to seek some help, but getting to that point where we can get someone in. And then secondly, I'm teased by the comment that it's a behavioral health. It's the same as medical. And I'm thinking here, you know, I go to the physician for an annual physical. Should I be seeing you annually to see if I'm behaviorally fit?
Yeah, those are good questions. So he asked, you know, what services we might have in place for a family member that's having some issues, and also would we recommend some kind of an annual mental health checkup. So let me start with the first question, which is we are open 24/7. So we do have folks walking in. The caveat is we're not a fully functional medical hospital. So anyone who's taken an overdose, who has some addiction issues too, we will probably send them out to Lancaster General's ER to be what's called medically cleared. So we make sure there isn't any medical issue. We've had, you know, somebody 70 years old walk in for the first time having a behavioral health issue. We need to check out and make sure there's no medical reason for what's going on with them. So most of our admissions do come from LGH and their ER. So they go there, they would get medically cleared, and they'd get transferred to us. We do on occasion, and we can on occasion, take individuals directly. So we have a 24/7 intake line. I would encourage you to call that intake number. Mike, did we bring by any chance the write-up on how to refer, the number, phone number?
No, but I can get it for them to distribute.
Okay, if you could get it to them to distribute. So there is a 24/7, you know, line that you can call, you can talk to someone. A lot of folks will actually make an appointment to come in, because this way we can make sure they're not waiting and they're not coming in the same time we have an ambulance pulling up with somebody. What would happen is that they would send, if they're coming from LGH, they would send referral information. That information would be reviewed by a master's level clinician and a psychiatrist, and a decision would be made whether to admit or not. And if we are going to admit them, they would be sent by ambulance from LGH to us. With our walk-ins, if they need to be medically cleared, we will send them back to LGH. And I know that's a little clunky, but we can only do point of care testing, so we can do some dipstick tests and that kind of stuff. If it's someone healthy and it solely seems to be a behavioral health issue, we can admit them directly. So, you know, those are kind of the avenues you would use to get in our hospital. Your question about whether or not you should have an annual checkup, that's interesting. There is a group of folks, and there is a whole push to do that, especially as children are growing up. That, you know, and part of your pediatrician's visit with children should be part of, you know, have you seen any, you know, unusual behaviors? Is there some extreme anxiety? Because addressing those problems earlier makes it easier to change those behaviors. So I would say that I can tell you that many doctors' offices in this county are using oh my gosh, what's it called? It's like an 8-question behavioral health screening thing, and it asks about depression and things like that, and that's part of the Let's Talk Lancaster initiative. And I'm sorry, what was it? Okay. There is, so a lot of medical doctors are already doing it. They're asking some kind of screening questions. Usually it's a self-report. So that's already happening in many practices, and it is an initiative that's starting here in Lancaster.
Thanks for coming. You mentioned that you do a lot in group settings. Could you kind of touch on that? Yeah, I know that kind of might vary from your adolescents to your adults, but you know, and maybe even the psychology behind the programs that you put in place.
Sure. So, you know, I think we do, we start each day with kind of like a goals group. So it's kind of where individuals would be asked to think about what's kind of the small thing that they would like to accomplish that day. And it could be something as being able to sit in a group later on, our process group, our more therapeutic group the entire time. It could be something as simple as start a conversation. It could be call home. And at the end of the day, there's a wrap-up group where we also go through, how did you do with your goal, and how did we help you, and how did we not help you? In addition to that, there are like the creative arts kind of groups. So there will be a music therapy group or an art therapy group. The gym, there is gym time scheduled every day. Some of this is physical wellness. And, you know, there is, again, a science about the creative arts and learning how to use your leisure time that's healing and healthful. But some of it is also just fun. And I say, you know, sometimes our folks don't have a lot of fun. And it's okay to have a group. So we do karaoke once in a while. I don't know that there's a therapeutic benefit to that other than it's fun. And that's okay too. And then we do our therapeutic groups. And those are our cognitive behavior therapy, dialectic behavior therapy. And we do things, there are specific modules, there's worksheets, and there are things like teaching folks distress tolerance. So if somebody says something you don't like, or if your family is again criticizing, why can't you stay employed? How do you manage that? There's also groups about learning how everybody has kind of like a different sensory diet. And what works for Mike to calm down might be very different than what works for me. So helping folks discover that, you know, a hot shower is really great for me, but Mike might want to curl up with a book, and that works for him, is part of what we work with people on identifying what sets you off and what works to bring you back, to calm you down. So you can avoid those triggers and not put yourself in situations where you might get agitated to a point where you need to be hospitalized again. But also, how do you manage your agitation? How do you manage your dysregulation? So those are the kind of groups we do.
Thank you so much for coming and sharing another medical resource that we have locally. Is there any way to give us a rough idea of either a minimum stay or an average length of stay? And could you maybe describe, I know it's variable, but something like a typical day for one of the persons who's in the facility? Thank you.
Absolutely. He asked for what is kind of like the average length of stay and what a typical day might be like. So Our length of stay, as you mentioned, it does vary. I would say our average length of stay is like 8.5 days. It tends to be longer on adolescent units, and it tends to be longer on psych med units. It might be shorter for someone who has, we've had folks come in with a situational depression. Somebody got, I'll give an example. This wasn't the example we had recently, but someone lost their job, got very depressed, thought about ending their life, came to us, we admitted them. They got a job. So their length of stay was like 2 days because the precipitant and the issue that caused their depression went away. So we do get some cases like that with very short lengths of stay, but that is pretty unusual. So I would say about 8 days. You know, a typical day is that folks wake up, we start to do the medication pass. Most meds are given like 8 in the morning. We start to do that at 8:30. They usually go for breakfast. So they'll go for breakfast down to the dining hall. They go as a group. It's a typical cafeteria. I have to tell you, our dining room is fabulous. Most of the staff eat there, and we do subsidized meals. Our director of food service was actually a chef and had his own catering business. So we are so fortunate. So folks eat breakfast, go back to the unit. They would finish our med pass, and they would then go into that what do you want to accomplish group today. That first group we have to kind of kick off our day. At 9:30 we do our meditation, and that usually falls during that group. So they stop and we all meditate. And then they go from group to group to group. So they might have gym time, they might have a creative arts. We try to do more the therapeutic heavy groups in the morning because folks just tolerate it better. We try to do more of the creative arts stuff in the afternoon. You know, lunch is like 12. We do visiting hours from 5:30 to 6:30. So they have about 5 or 6 groups a day, I'd say. During this time, you always see a psychiatrist. So the psychiatrist will come, you'll be pulled out of your group from anywhere from 10 minutes to a half hour, depending on what's going on with the individual. You'll see a psychiatrist every single day. We do have medical providers too. We have family practice CRNPs, and we do have one medical doctor who rounds twice a week. But for the most part, your interactions and your treatment is led by a board-certified psychiatrist. So you'll see your psychiatrist, you'll see your social worker. Your groups are led by master's level clinicians, which are either social workers or creative arts kind of people. We also, so you'll go to your groups, dinner's around 5:30. Visiting hours then happen for an hour. There is one more group after that. And then we didn't call it bedtime because these are adults, they're not children. We do try to wind down the unit around 10 o'clock. You know, some folks do have like, you know, sleep dysfunction and they sleep all day and they're up all night. So we do try to work on that, but we're not in the business of dragging people to their bedrooms and locking the door. So we will keep the TV on low if someone really needs it. But in general, if you don't sleep well, you're not going to feel well. So sleep hygiene is another important piece of what we do. We do play music on our overhead system 3 times a day. We do vary the music, but it isn't like hard rap or something. It's not exactly dentist music, but it's peaceful. And we have headphones that folks can use individually to play what they want to play. The phones are on when it's not group time, but they can have free access to the phones. They can shower when they want. Some folks like to shower in the morning, some at night. There's laundry facilities on every unit. We ask them to take we do have some folks who show up with everything they own, and we have a large storage closet. We don't put all that on our suites. We try to keep like 3 sets of clothing and stuff because it just gets too much to manage. So that's pretty much it.
Do you provide follow-up or referral services after discharge?
That's a great question. And so I personally go over with my leadership team the discharges every day and the ones that are planned for tomorrow. And I listen for a few things. One is I listen to know where they're going, where they're gonna live. I listen for when their therapy appointment is and when their psychiatry appointment is. Because we can discharge you with a script and the best treatment in the world, but if you don't have a follow-up appointment, if you don't have someone to help you in the community, you're gonna end up coming right back. Our goal and my demand is that we have those appointments within 7 days. If someone's high risk, I want the appointment within 3 days. We've discharged people who had appointments that same day, that afternoon. And so we actually watch that very, very carefully. One of the things I'm going to start monitoring more carefully after some of the feedback I got yesterday was I want to know when the family meeting is, because we reach out to the family within 48 hours of admission when we have permission, and we do have to get permission, and then we have a family meeting prior to discharge. But I did hear at least one instance where that didn't happen, so I will now be asking that question every day when the family meeting was, because I do think we understand that, especially folks who have severe mental illness, it's really the family that helps keep them afloat in the community, and their faith communities sometimes. So it's really important for us to partner with them and to make sure, you know, they're aware of what the discharge plan is, when the appointments are, where the appointments are, because they often help the person get there.
Jane, the district attorney was here a couple weeks ago, and he said with the opioid crisis, there's lots of challenges there. And he used the figure that it takes as long as 270 days to take a person with opioid addiction and get them so they're cured, we'll call it. Mm-hmm. How, you're talking about an 8-day stay on average. How do you deal with that? How's the opioid stuff help affect you? And how does the insurance affect you? Because so many times when I've looked at insurance policies, the most severe limitation is on mental treatment.
Absolutely. I think despite the fact that some claim there's parity, there is, the question was, how do we deal with individuals who have an opioid addiction when the information being relayed is you need 200+ days to be in recovery from opioid, and how do we deal with insurance and, you know, getting folks the services they need with an 8-day length of stay? It's a challenge, is the answer. I mean, we are pretty aggressive about working with the insurance companies, but you know, we get 2 and 3 days approved at a time. So we have to go back and represent, and this is where it becomes a balance, because we're trying to be strength-based, but if we put in the record all the good things they'll do, discharge them. They don't need to be there. So you really do have to balance between kind of how we say and what we document, and what the, you know, to keep people and get them the services they need. It is, I think it's a balance. It really is. When you look at, you know, out-of-network costs for individuals who have behavioral health disorders, it's much higher than physical health. If you look at, you know, so although the co-payment is the same, there aren't any providers. The panels are much smaller for behavioral health. So you're getting an out-of-network cost. And we've had folks admitted who their out-of-network cost was $10,000. It's just, it's unbelievable. So we're constantly being assertive with the payers. Mike has done a fabulous job about negotiating. That's what he takes the lead on, and working with our payers and getting those single case agreements if they're not in our network, and arguing for it. You know, we've had some kids come in, the college students, and they wanted to send them to Philadelphia. And we said, no, we're not sending these kids to Philadelphia. They need to be served here. And we've been pretty successful, not always, but pretty successful. But it's a struggle. You're absolutely right. Thank you.